My dear friends, seniors and my junior colleagues, this is a very proud moment for me and I am very glad আজ থেকে প্রায় 23 বছর আগে এই মুর্শিদাবাদ থেকে যখন ডাক্তারিতে পড়ার জন্য কলকাতায় যাই MBBS NRS মেডিকেল কলেজে দ্য মিলেনিয়াম ইয়ার 2000 ট্রেনে যেতে যেতে বারবার মনে হতো যে যদি একটা মেডিকেল কলেজ এই মুর্শিদাবাদে হতো। তো টুডে not only the medical college is a complete cardiac foundation is there and I am talking on the stage and I congratulate Baharampur Cardiology Foundation. Now today, before going to discuss on PCI or CABG, I just want to highlight few points in the history of CABG. Now this gentleman actually it just century years ago he first conceptualized the CABG and in the year 1912 he was awarded Nobel Prize in the field of medicine. Now since then the coronary artery disease, rather it was a management and challenge in management the ischemic heart disease. And the main intention for treatment of ischemic heart disease that was to prevent angina and to prevent death. Now in early 20s, the lots of invention and the research and experiment was happened, and this was the landmark event that Beck's technique, Arthur technique, Weinberg technique and Carroll technique. This was the pre-CABG era. And after that, in 1962, when coronary angiography comes, and then we understand the actual anatomy of coronary artery. Then 1964, it was the year of CABG when endothelial to endothelium anastomosis was done. Now after 10 years or 12 years, PCI comes. Now with this long time, there are lots of invention, innovation and technological improvement happened, and in parallel CABG and PCI come together. But today it is not the debate, but it is a time of the modern concept of heart team, and now we really happy the heart team approach is not only confined in the mega city, but it also come into the Murshidabad district. Now this is our patient as we already discussed. So what will be the management, whether it's CABG or PCI? Now when the option of revascularization comes, lots of questions come into the mind, both the surgeons, cardiologists as well as the patient family. Dr. Babu, বাঁচবো তো? যদিও বা বেঁচে ফিরি আমার লাইফটা কীরকম থাকবে, কোয়ালিটি অফ লাইফ, অত বড় কাটবেন, ব্যথা হবে? তো দিস অল আর মিথ, বিকজ the primary intention of today's management of coronary artery disease is the complete revascularization. Not only that, it should be durable and it should be acceptable to the patient. So the primary goal to achieve that is that the procedure should have their survival benefit and there is no or minimum repeat revascularization. So my surgical point of view, what options available for this patient actually? This is the gold standard nowadays for revascularization, this off-pump CABG. Now we are doing almost 95 to 99% of patients treatment with this technique. Apart from that, we have bypass surgery with arrested heart we have MICS, we have robotic as we already discussed, and we have hybrid approach, that is actually the real cardiac heart team approach. So we, the surgeons, have this type of stent with hand. There is the lima, left internal mammary artery, right internal mammary artery. Not only that, there are RSVG, venous graft, as well as there are lots of other grafts we can use. So this is the most commonly performed procedure nowadays. And lima and RSVG is the most commonly used conduit. Now the best solution, surgical solution for this particular patient is lima Y with total arterial revascularization, no doubt about it. Now it can be done with MICS. So now the review article, what article says? If you look at the Bari trial, you can find that in a diabetic patient, we can find the mortality rate is significantly higher in PCI compared to the CABG. Not only that, in syntax trial, it also shows that repeat revascularization is always higher in PCI group. Now in Excel trial, this is the most controversial trial nowadays. Even that also proved that repeat revascularization is not more in CABG, it is in fact in PCI. And pre-combat trial, all this study shows that repeat revascularization is always higher in PCI. This is a myth. What we are in our concept that repeat revascularization is more in CABG. It is not true. And survival benefit, as I already told, that the mortality rate not high in CABG, it is in PCI. So Excel trial, the most controversial trial, they showed that there are advantages of PCI over CABG. However, the most important point to be noted that repeat revascularization was not included in this study, and peri-procedural MI included, but the definition has been changed, and selection criteria was the different. And in this Excel trial, based on this Excel trial, the whole recommendation has been changed. But still, if we look at the left main coronary artery disease, still the primary treatment is not the PCI, it is equivalent in milder group, those who are syntax score less than 22. But however, more than 22, syntax score is always CABG is preferred over PCI. Now the gold standard and the most recent study, that is Nobel study, that already proved that the myocardial infarction as well as repeat revascularization is always higher in PCI group. So CABG for this particular patient is best treatment for management. Now Nobel trial also concluded that drug-eluting stent with PCI was inferior to CABG for clinical outcome at 5 years follow-up and revascularization of unprotected left main disease. This hazards was highest with CABG in initial 30 days, but after 30 days in a long-term basis, the CABG is always better than PCI. So what is the current recommendation? If you look at the recommendation, you can find the only group that is non-LAD coronary artery disease, that is circumflex or right coronary. This is the only indication which overtake PCI over the CABG. In all other group, CABG is always the first technique and will be the class 1A indication for revascularization. So why this recommendation comes and why CABG is better? The basic difference of CABG and PCI is CABG we are always dealing with a clean area, the non-disease part of coronary arteries, whereas in PCI they are we cardiologists are dealing with a disease area. So disease will grow like crazy, and new disease if occur in after CABG, this will take time. at least 5 to 7 years to block the graft. As the initial part is over, the graft will act very good, particularly in arterial graft. As you all know that our physiological vasodilator, that is nitric oxide, is generated or liberated from the vessel wall, and it always dilates the vessels, and according to the need, the vessel can dilate or graft can dilate and constrict according to the need of the blood supply. So arterial graft, as the other word we call it, is a living conduit, whereas in PTCA the stent is a fixed tube, it cannot dilate. So in conclusion, the CABG is always better for the management of this particular patient, not PCI. And if still we are ready to do PCI, in particular this type of complicated and complex coronary artery disease, we should our backup CTVS with cath lab facility. Thank you.
Thank you, Dr. Hoque, for your excellent deliberation. Shall I ask the
Yes, sir.
From the question, it appears to me this is a clear-cut patient of stable coronary artery disease.
Yes, sir. Yes, sir.
So, you know from the different trials like CAST trial, Veteran Affairs Cooperative Society, or CABG, or stable coronary injury, stable angina. It is a 19-year study.
Yes, sir.
And CAS is almost 10-year study. These two studies never showed any survival benefit, except in relieving of some symptoms. So should we go for the complicated CABG for a stable angina patient? Number one. Number two, why then another option, you have discussed about CABG and PCI. Why not GDMT or OMT is included here?
Yes. Thank you. This is a very good question. First question, answer of the first question. In practice, if you look at your patient profile, most of our Indian patient profile is very low, poor socioeconomic status, and if we continue with this type of disease and critical LAD lesion and bifurcation lesion, the number of medicine is so high. At least 6-10 medicines can be taken per day. If we can revascularize this patient and we can offer the medication as well, the only one single antiplatelet after 1 year. Initial 1 year we usually prescribe dual antiplatelet, but after that only single antiplatelet and statins and sometimes beta blocker, that is enough. So this is, I think, the in our Indian scenario, particularly low profile patient is a very good option, not the CABG or yes. Second question answer, the optimal medical therapy. Sometimes it may happen with this optimal medical therapy, there will be chance of MI, recurrent MI or repeat myocardial infarction. So why we can take a chance? We should do revascularize and give the good quality of life of the patient.
Any other question? Any question? My opinion is
Yes,
that
sir.
suppose there is a block in a water pipe.
Yes, sir.
What will be the treatment? Treatment is to remove that block.
Yes.
But human body is a non-linear, unpredictable and dynamic body.
Yes.
It is very difficult to say beforehand that if you relieve the block, the patient will survive much longer. What's your take on this?
If you relieve the blockage, if you really want to relieve, yes, there is some amount of chances of complications, but as the medical science developed, technology improved. So as you know, in 20 years back, the message was like that, if you go for operation, you will die. And that the same message is circulating today as well. But technology and medical science, there are tremendous improvement. And really, I am frankly telling you, in a good dedicated setup, the CABG mortality is not so high. It is just 1 to 2% or 3% like that. So the complete revascularization, the main problem is not the coronary artery. It's the fear of the sternal bone cutting and the exposure of anesthesia. That's it. But if you consider the operation as a coronary revascularization, it's just like other operation. And patient may go home within 5 or 6 days. So why we cannot take the chance of this good opportunity? We should do it. And my take home message, if there is a critical blockage, we should do intervention, because we should not take any chance. As we know that emergency procedure has its own hazards and the complication rate is always high. Thank you.